What's up, everyone? In this new series, I sit down with my longtime mentor, Dave Bacani, who you guys are going to get a chance to meet. He's been my mentor since the beginning of my career, and he's been very impactful in my journey to becoming a more confident therapist. We cover a lot of great stuff in this video, so I hope you like it.
Gee, what an intro. Thanks, Qui. Long time no see. So I'm Dave Bacani. I'm the clinical director for Soleil Physical Therapy and Wellness. I graduated BU in 2001 with my master's in PT and worked in various outpatient settings throughout the years until in 2015 became the clinical director for Soleil Physical Therapy and Wellness and Quantum PT, our sister clinic back in the day. And shortly after that, I went back to school, got my manual therapy certification, and then a year later got my doctorate. Then got involved with a continuing ed organization, the American Academy of Manipulative Therapy, because I was really interested in spinal manipulation, dry needling, those types of things. And then I got my certification in dry needling shortly after that, and here we are.
What if you noticed that has been a pattern for some of the students that you have mentored in the past? Was there some particular pattern that you've noticed or that you've picked up on?
Well, yeah, being here in the Northeast, there's a proclivity to kind of follow a format that's familiar to the area. So I don't know if people know this, but in different parts of the country, physical therapy is different. And there are schools of thought that are predominant within the region. In North America, near Canada, there's different manual therapy approaches. Australia, there's different ones. The Norwegian approach is another one. And at BU, where I went to school, the Norwegian approach was predominant. So I just noticed that students from certain schools were more familiar with those approaches as opposed to other approaches. And I felt that knowing what was more effective as opposed to just one approach, but taking from different approaches, was way more valuable in the long run. And that's something that I had to learn later on in my career. Because I was kind of indoctrinated into the Norwegian approach, graduating from BU. And then I got exposed to different kind of schools of thought. And I just kind of took from definitely some valid assessment tools in the Norwegian approach. It took from them, took from the Maitland approach, different other approaches through many years, and just culminated my own style.
I think when I graduated in 2022, I think, so my school combines a lot of the Maitland approach and a little bit of Kaltenborn as well. But I felt like when I started doing my assessments, like my history intake and my objective measurements, it was just like a whole bunch of stuff thrown at me. And almost like I felt like I was almost disorganized. And like for someone who's feeling disorganized or maybe just overwhelmed as a new grad coming out, like what advice would you give for them?
Well, what worked for me was following the signs and symptoms model by Maitland. And the basic format is when you have a patient with a musculoskeletal disorder, you do a very thorough subjective. Spend a lot of time trying to ask questions, big picture to little picture, that helps narrow, your basically your hypotheses. And then from there to employ a signs and symptoms approach to the assessment, which would mean hypothesizing and then testing and then treating and then testing again. So yeah, hypothesis, test, treat, retest to see whether or not your hypothesis was correct. And to me, that's really the only way to effectively treat patients, is to go through it with a scientific, method, and then coming out with the best approach to treating the patient.
In the 25 years of you being a clinician, have you ever thought about mentoring anybody? And is that something that you're interested now in this phase of your life in PT?
Yeah, I think mentorship is one of the main things I'd like to get into, and I enjoy. So I mean, what are you going to do? With 25 years experience or so, I mean, you got to give back, right? And, I mean, that's just the cycle of life, you know? So, and do I enjoy it? Yeah. Yeah. Did I enjoy mentoring you at the time? Absolutely. You know?
I thought you were gonna say. I swear, I thought you were gonna say, nah, not really.
Yeah, it's always nice having answers that other people don't have sometimes, right? And then,
Yeah.
and to be able to teach them, and then also learning through them. I mean, I don't have all the answers, right? And then you also learn as a mentor through your mentees, you know? So,
What are some things that you've noticed that new grads can improve upon, right? First coming out of school.
so you know, it's interesting. It's not even just new grads, but even some seasoned therapists too, and even including doctors. Believe it or not, you'd be surprised. I'll give you an example. I had a patient not too long ago who was status post, you know, right ankle ORIF, and she wasn't really progressing well with her ankle range of motion. Her dorsiflexion was like negative, and she wasn't with us. She was with a different clinic. I got her after the fact. So after 3 months of physical therapy, her ankle dorsiflexion was still like less than neutral. She walked into her surgeon's office 2 weeks ago, and her surgeon's like, "Wow, that's not good. We might need to do an operation to elongate your Achilles tendon if that range of motion doesn't improve." And she told me that. I'm like, elongate the Achilles tendon? Wait a minute. That's only if you have a contracture. What if it's actually an ankle joint stiffness problem?
Right.
Let's take a look at it, right? Hypothesis, test, or treat, right?
And then retest.
Retest, right?
Yeah.
And so I did, you know? So I looked at it, I tested it. Lo and behold, ankle joint mobility is poor, you know, extremely hypermobile. So she's having a conversation about going under the knife again for a condition that she might not even have, for an issue that needs to be addressed by physical therapy, and that, you know, hopefully will be addressed. This is a new patient to us. And I'm going to retest after our interventions whether or not it's true, whether or not it's really the ankle mobility that's the problem and not a true, like, you know, heel cord contracture. So what does that mean, right? So what does that mean? What would I like new grads to have? Is that kind of rationale in assessment to really determine and find out what's the cause, what's the problem of the patient's impairments, why are they here? Yeah, assessment skills, it's huge.
What is inside the assessment skills? Like, we talking about history intake? Are we talking about good objective measurements? Like, what are we talking about in your assessment skills that you like, that you would give? Like, give me a priority list in your mind. What is
So, number one is you have to have a really good subjective. Spend time, an inordinate amount of time, just listening to the patient, right? And from there, you can already start to hypothesize what the cause of their issue might be. So you should have, you know, a few ideas initially just by talking to them. And what that does, it actually limits, it reduces the amount of time that you need to actually perform your objective measures and actually lay hands on them. And for some patients, that's actually beneficial. The less, you know, testing you do on a patient, the better, especially if the conditions are very irritable. You don't want to have to put them through a rigmarole of a bunch of tests just for you to figure out something that you could have kind of narrowed down with your subjective. So the subjective is huge. Develop several hypotheses, and then select the best objective tests to test your hypotheses, and then go from there. But what do you already know that you think needs to be put out there?
I definitely think that the subjective is so important. I think subjective history is probably it's more important than objective, in my opinion, because without a good subjective history, like, you don't know what you're looking for at that point. Hence, you can't come up with a hypothesis.
Here's the other thing. You're right. I mentioned the signs and symptoms approach by Maitland.
Yes.
So that's the whole model of the SINSS, SINS.
Yeah.
So severity, irritability, nature, stage, and stability.
Yep.
I use that all the time. Like that really helps me hone in on, it really helps me develop an accurate diagnosis, PT diagnosis, and also for treatment. Because it helps me select the right exercises based on where the patient's at in their rehab, in their recovery. But I think for new grads, it's important to have that systematically, like it needs to be there, it needs to be filled out, not only in their head, but on the paper, because it helps to solidify it in their head. So that's why I made you fill it out. I made myself fill it out earlier on.
Yeah. I'd say like the history intake of that, acknowledging like how iterable the signs and symptoms are. Those are, I think those two are really the bread and butter of everything. I think that the assessments, the objective measurement itself comes from the history intake.
Right.
And then from there, you can decipher your hypothesis. Is this like
Then your assessment.
Yeah, in your assessment. So I definitely think that that's what I kind of want to see from you, right? I think that's really important. I'm looking at other people's history intake, and I definitely think after a while of seeing 14, 15, 16 people a day, the history intake, the subjective,
It falls by the wayside.
Yeah.
It does, though. Even here too, I see it. Me being the primary therapist, it falls by the wayside a little bit. So maybe in the written form, but when you're actually doing it, I'm still spending a lot of time talking.
Oh yeah, absolutely. You're not like negating.
Right. I'm not cutting corners in that way.
Yeah. So that's what that's really important. I think when you were looking at my notes too, asking me like, okay, did you check this? Did you check that? Right? That was very valuable to me because when I came here, one of the first few things you said was red flags are really important. Like somebody could walk through the door and, we're not the only people that are seeing 16 people. These doctors, all these other clinicians are seeing 16, 15, 30 people a day. So sometimes they do go by the wayside and things are left unchecked. But if we can be a little bit more, if we can have an organized checklist, right?
Right.
To make sure that we're asking the right questions. Like, how did you get this lower back pain? Oh, I got it through a motor vehicle accident. Okay, like I got to go through my motor vehicle accident screening, which is like like for example, the Canadian C-spine rule is a
this
good
being
one.
taped?
Yeah, it is.
Oh, okay, great. We're missing something. Yeah.
Yeah, the Canadian C-spine rule is a good one.
Auto anchor rules.
Yeah, and even like the cranial nerve testing. Right. Those are the simple and straightforward assessment red flag tools that we need to always like have in our toolbox. Yeah. So I want that. I want to showcase that. I want to showcase like your approach because there's stuff that I feel like I'm missing. There's stuff that I feel like I'm missing in my routine that could be polished and improved. I care about this craft. That's why I care about this career. I care about this craft. And so at times it does kind of, I get burned out and, the notes start to slack off. And when I start to feel like, I could have done better, that's when I realize like I need to go back into the books. Let me polish some things up, but I want to just kind of bring it to you because I think this is important. I think it's important for new grads to see this, that there will be points in your life that you will work, you're really driven and you really want to learn so much, but then you burn yourself out because, clinics it's just the nature of the beast in outpatient. You have to see 12, 15 people a day. And, how can we prevent that burnout? Is there a system that we can create for these new grads?
Yeah, I mean, I think, so is this?
Yeah.
My bad. Yeah, everything's being recorded. No, to touch upon what you mentioned, having a system for assessment, an effective system for assessment. So, there are times where I've tried other systems and it didn't work on a lot of patients, like every patient, right? Like sometimes some assessment measures required the patient's feedback a lot, like better, the same, or worse. That's another one. Like symptom localization with the Norwegian approach is a lot of like testing that requires the patient to say, are your symptoms better, the same, or worse? And then going from there systematically to the next step. Well, sometimes patients have a hard time telling you whether or not something that you just did made it better, the same, or worse, especially if it's really nuanced, So what I found was with the Maitland approach, with the signs and symptoms approach, it was a little more simple. The testing that I utilize is more straightforward and simple. Hopefully the specificity and the sensitivity is better. And that's what I gained through going back to school to get my doctorate, is to start to reacquaint myself with the most up-to-date research in terms of not just assessment skills, but also treatments, right? One thing that I really enjoyed was knowing that treatment-based classification was big at the time of when I went back to get my doctorate, and I utilized that a lot. Putting hypotheses into large baskets, and then from there through the signs and symptoms model and the hypothesis, test, retest model, being able to hone what I think is the actual condition, reason for their, symptoms. And so I think the signs and symptoms approach has been really important for me and really effective, and I stick to it.
All right, and that is a wrap for today's video. So moving forward, Dave and I will be sitting for a whole series where we'll dissect some of my past evaluations, look at my treatment choices, and let you see firsthand on how he coaches through complex cases. If you're a new grad and you got some value out of this, hit that follow button. We'll be dropping more content just like this to help you build clinical confidence. Till next time, I'll see you in the next video. Bye everyone.